we're excited to continue this conversation about topical hemostatic agents in the ambulatory care setting. Dr. Ito unfortunately couldn't join us for this additional session, but we wanted to answer some common questions that we get from colleagues and trainees about these agents, and also give a couple practical case examples of how to use them. And finally, just summarize the most important points from our presentation, and that you should really take home with regard to the learning objectives. So we're excited to add this additional section, and thanks for joining us.
Yeah, it's great to be here. It's good to see you again, Megan. I think we had a really good discussion last time, and I think we can expand on that and try to sort of give our own personal experiences about how we use these agents and what their role is, particularly in our lines of work with regard to trauma and critical care. We're never at a loss for needing all the help we can get sometimes in stopping bleeding, but there are definitely appropriate and inappropriate uses for these, and it's important to recognize that.
Yeah, I think for sure. And I think from the get-go, one of the most common questions that I get from trainees regarding all these different agents that we have available to us is can all of them be, I guess, left in there, so to speak? Or are there any of these agents that need to be removed? Are all of them going to be absorbed? Or how do you differentiate when you're making a decision? So I don't know if you get asked that or if that's a problem for you also. But
I feel like that is a question I get asked. It's more, I feel like a slant on that is that I just get told there's a product and this is what I have to use on it because this is what we have in stock. And so that kind of, in some way, obviates the need to think about such things. And yet that's important to think about because, nothing is benign in medicine, as you well know. And so knowing the mechanism and the longevity of the product and how it's absorbed are important, but sometimes that's not always in the full frontal of anybody there that's using it at that time. And it can be a quick split second decision and you're hoping for the best, but really sort of knowing the armamentarium that exists within your institution is critical to know what to use and when, I would say.
For sure. And I think when it comes to trauma, it's interesting because we have such a broad spectrum of operations that we do and such a diversity in pathology that we treat. And I think it can be overwhelming for providers when they start to implement THAs into their practice. And they do a first case and they use a particular THA, and then the next case comes up again and they think, well, I'm going to use a topical hemostatic agent. Well, I'll use the same one I used last time. And so an example that I'll give when it comes to trainees would be something like Celox, which we use commonly in severe hemorrhagic shock. But this is an example of an agent that is not approved to be left inside, so to speak. So this is a temporary hemostatic agent that's granular in nature. And so that's really for when you're going to go back and wash it out and do another operation. So that's not one that trainees that we should be teaching trainees to use, for cases in an ambulatory setting where somebody's going to go on and that agent's going to be left in.
Right.
And another such example would be there's a variety of gauze products on the market. So something like Quick Clot. Well, that's just a temporizing agent, and that's not something that could be absorbed like the agents that we discussed in our presentation.
I feel like I've heard those same conversations in every case that I've done in our line of work, and I think you bring up a great point. Our line of work as trauma surgeons is obviously different than the outpatient or ambulatory setting where these may be used in a different vein, no pun intended, of trying to control bleeding, and the outpatient and inpatient settings, even the inpatient non-trauma settings are different. And I think understanding that there is a wide variety of topical hemostatic agents, as we previously discussed, and it's not just one group or even one subgroup, but broad categories of different things you can use. Quick Clot, Surgicel, flowables, injections, things of that nature, that are all suited for different appropriate purposes. But talking to your colleagues and sort of doing your due diligence and research is important so that you're using it in the right type of environment. I think often, like in our line of work, I always go back to the bad liver injury, and something along those lines. A question that I often get posed is from residents, well, can't we just put some flow seal on that as an example, or TIS seal, or what have you? And I try to impress upon them in the heat of the moment that, controlling surgical bleeding is done through sutures, clips, definitive cautery, things of that nature. These agents are wonderful adjuncts, but they are adjuncts, and you need to pay attention to controlling bleeding first from main, ooze, or raw areas, and then thinking about these adjuncts to help that annoying ooze that happens afterwards, but realizing that these are not definitive, but simply adding to what you're trying to do to the patient already, whether you're in the inpatient or the outpatient setting.
Mm-hmm. Yeah, no, I think that's an excellent point. And I think probably the most important point from our presentation that we're going to have to keep coming back to. And that's just that the role is an adjunct, and it's no substitution for good surgical control of bleeding.
Right.
And I think that's important. Another question I get asked about a lot is whether or not these agents increase the risk for infection. And I think we think about that, especially when we're doing sort of relatively more elective cases. I'm sure in your practice, you probably repair inguinal hernias or take gallbladders out. And I'm sure you've thought of the scenario where things are just kind of just a little oozy or just a little wet. And the question is, does leaving these products in, do we put patients at risk for infection?
I think that's a great point, Megan. I think when we're using these agents, I fully admit that I'm not thinking of infectious complications at first. I'm thinking of stopping bleeding. And I think most of my colleagues that I've talked to have felt that way as well. But to your point, if I'm doing the elective gallbladder and the gallbladder fossa and liver bed are oozy afterwards, I'm putting flow seal and Surgicel and everything looks great. Then they come back a week later with a biloma on the CT scan, and you're wondering, is that really leakage, or is that just the remnants of something that I left in good faith to stop bleeding, but is causing the body to have what could be a very natural reaction? But here we are in the ER at 2 a.m. with a white count of 15 and needing some intervention. So as we have both said, nothing is benign. You have to think about those things when you're using them.
Yeah, no, I totally agree. I completely agree. I think, for sure there is some amount of risk for infection associated with these agents, but it's really difficult to quantify. There have been some studies that have tried to look at if you leave them or if you don't leave them, but and maybe potentially there's an increased chance for infection. But it also, as you've alluded to, relates to how you diagnose an infection. We're doing postoperative imaging, and these products are visible on postoperative imaging. If you're using NewNet or you're using Surgicel, there's going to be something there that's visible on imaging. And that doesn't necessarily diagnose an infection, though it might have sort of similar characteristics. And so I think, what I try to tell trainees when they ask about this is like you said, the important thing is, do you need the product to control bleeding? So again, not for surgical control of bleeding, but are you concerned that there's going to be sort of a generalized ooze afterwards, and that would be improved by use of the product? And if so, then it's necessary, and only use what's necessary. So a lot of times you'll use the powder, or you're saying Surgicel, and just cover the area that's at risk, the area that's oozy, but don't put excessive amounts of product in that aren't necessary. And I think that's really the way to optimize use of these products, so that you control the ooze, but you minimize the risk for afterwards infection, or even for just abnormal appearance on postoperative imaging, if that's how it presents. So
could not agree more. It's the adage of, I guess, not measure twice, cut once, but measure twice, pour once there, and, be precise with it and don't overindulge. Because, as we talked about in the podcast, with medicine being what it is these days, and healthcare in general, there's a cost associated with the use of these products there. And that has to be taken into account when you're using them. Nothing is free to the patient per se, but knowing sort of how these products come onto your shelf at your institution and knowing the cost of them can sometimes be a factor in saying, maybe I should use product X over product Y, or do I need to just hold a little manual pressure myself at first, and that will solve the problem or prevent any, offsetting downstream effects. But really knowing sort of the behind the scenes work of what you're using is also important, I think.
Yeah, definitely. Another question that I sometimes get asked is whether or not these products that we're putting in there, that we're leaving in there, are they systemically absorbed? So that's sometimes a conversation that we have to have about it too. And as these products aren't approved to be systemically administered, so we have to sort of be cognizant about that, where we're putting them and what the risk is there. And something I always bring up with trainees is, if you're intending to use something like Cell Saver, then you have to be aware that you don't want to administer this product centrally or systemically. And there's a risk for that if you're collecting things from the surgical area and then giving it back into the bloodstream. So.
Absolutely. And that really, to your point exactly, that especially in the outpatient or the inpatient sort of non-emergent setting, really speaks to, I think, your preoperative planning and what you expect the operation to be and what you tell the patient about the operation, particularly if there are religious concerns with the patient of what products can be used or cannot be used, and also any coagulopathic or bleeding disorders that may need to be addressed preoperatively from an infusion or medication standpoint, because again, certain types of bleeding simply can't be controlled with any type of topical agent or cloth or netting or solution or what have you. But being mindful of factor correction, the clotting cascade, as scientific and boring as that might sound from what we all learned in medical school, but knowing what your patient's issues are ahead of time in general, as well as respective to any bleeding or coagulopathy, is key to maximize that beforehand, so that not only is surgical bleeding control, but again, precise use of these products in that setting can be appropriate.
Yeah, for sure. And I think, I would encourage providers, take a look at the insert for the products that you stock at your hospital or at your center, and just be aware. What are the contraindications for this product, or what are the risks? Could there be a hypersensitivity reaction? Where do these products come from? Might some people be opposed to the use of these products? Things like that. And I think, we've mentioned this before, but most centers really only stock a limited number of these. And Correct. So familiarity with the ones that you have. And then, another thing might be investigating other ones that are on the market. And then right. You can talk about, maybe we should carry this instead, or maybe we might like to explore this agent. But I think it's nice to have a variety of them for the reasons we talked about, the clinical factors that you're going to consider when selecting one, and then the performance factors. So I think you want to have some cheap physical agents on hand, but then you also want to have some fibrin sealants for that heavier bleeding on hand, and, right. and the whole spectrum. Some active agents for patients whose coagulation system is not intact. So I think all of those things have to be considered, and it's good to have a few different agents and really a variety of choices for the provider to choose from.
Agreed.